The relationship between the heart and the lungs is deeply interconnected. When the lungs are compromised, as seen in conditions like COR pulmonale, the heart must work harder to maintain oxygen flow throughout the body. This increased strain can lead to serious complications. Understanding this relationship is crucial as it highlights how respiratory issues impact overall cardiovascular health. So come on and let's delve into this vital system. Buenos dias. Good morning to each one of us. Paula, I am Daniela Marie from Section D. Together with Miss De La Cruz from Section B, we will be discussing about core pulmonale. To start this discussion, I am going to call on Miss De La Cruz.
Hola, I'm Mariangela de la Cruz from Section B, and we're going here to discuss the core pulmonary. So first is we're going to start with the anatomy and the function of the heart. So the heart is work as a pump to move blood around the body. So it has four chambers. We have right atrium, right ventricles, and left ventricles. So next, let's examine how blood flows through the heart. So first is the right atrium takes in blood carrying carbon dioxide. Then second is the blood is squeezed down into the right ventricles and take it to the lungs, where oxygen replaces carbon dioxide. So third, oxygen carrying blood around the lungs enter the left atrium, and the blood is pumped into the left atrium and starts its journey again throughout the body. So what is cor pulmonale? So, the definition of cor pulmonale is a condition that is result from pH which causes the right side of the heart to enlarge because of the increased work required to pump blood against high resistance through the pulmonary vascular system. This causes the right side's heart failure. So we have two types of cor pulmonale. So we have chronic and acute. So chronic is known as a long-term condition, and it can be further characterized by hypoxic or vascular obliterans pathophysiology, while the acute is known as a short-term condition. It as a result of a sudden increase in right verticular pressure as seen in a massive pulmonary respiratory distress syndromes. So let's move on with the pathophysiology of cor pulmonale. So we have start with the predisposing factors and contributing factors. When we say predisposing factors, it is are the elements that influence an individual likelihood or developing a disease or experiencing a negative health outcome. So we have the sex, the gender, and the heredity of a person. So next is the contributing factors. When we say contributing factors, it's something that help cause the disease. So we have the obesity, the chest wall deformities, the chronic hyperexia, and smoking history of a person. So both contributing factors and the predisposing factors can lead to a disease affecting the lungs, which also means that it can lead to a hypersemia, which is known as a low oxygen level in the blood, causing some lung diseases.
Now, let's find out on how lung diseases leads to pulmonary hypertension that eventually leads to the right-sided heart failure. So as we all know, lung diseases can cause damage to the tissues and impair lung function, such gas exchange. When there is impairment in gas exchange, it can result into reduced oxygen levels in the blood or what we call hypoxemia. When the body does not receive enough oxygen, it triggers a series of compensatory mechanisms to try to increase the oxygen delivery. In response to hypoxemia, the body's natural response is to constrict the blood vessel in the lungs in an attempt to divert the blood flow to areas with better oxygenation. As the pulmonary arteries constrict, the blood vessels in the lungs become narrowed, leading to a reduction in the overall size of the pulmonary vascular bed. The narrowing of the vessel and the reduction in the vascular bed increase the resistance of the blood flow in the pulmonary circulatory system. This elevated resistance causes the heart to work harder to pump blood through the lungs. So this causes pulmonary hypertension. other side, chronic hypoxemia due to lung disease triggers the body to compensate by increasing the number of erythropoietin, and a hormone that stimulates the bone marrow to increase the production of RBC. These situations are called polycythemia, an increased number of RBC. So when there is increased number of RBC, it also increases the concentration of the blood, thus hyperviscosity. So when the blood is thick, it requires the heart it requires the heart to pump harder, causing the pulmonary hypertension.
So directing to the pulmonary hypertension. So pulmonary hypertension is high blood pressure in the blood vessel that supply the lungs. Normally, the blood flow easily through the vessels, but these pulmonary hypertension, they become narrow or stiff, making it hard for the heart to pump blood into the lungs. They may cause symptoms like shortness of breath, fatigue, or chest pain. So starting with the primary hypertension, typically refer to the high blood pressure in the systemic circulation. Under a normal condition, blood flow easily through these vessels, but various conditions can cause changes in the pulmonary vascular bed, leading to pulmonary hypertension. So, entering with the pulmonary artery constriction due to hyperexia and acidosis. So, when we say hypoxia, it is a low oxygen level, while the acidosis are the low blood pH. These two components can lead to pulmonary vasoconstriction. So when we say hypoxia, it's the body or lungs doesn't receive enough oxygen. The pulmonary arteries constrict as its response, so leading to pulmonary hypertension due to the prolonged or severe hypoxia can cause sustained narrowing of the of the pulmonary arteries. Well, the acidosis, it is similarly when the blood becomes more acidic due to the factor like carbon dioxide buildup or metabolic issues. The pulmonary blood vessel may constrict, and it can contribute to increased resistance in the pulmonary circulation and lead to pulmonary hypertension. So it can cause a pulmonary embolism. So pulmonary embolism occurs when there's a blood clot, usually from the legs or the deep veins, travel to the lungs and block a pulmonary artery or its branches. Although it is a primarily caused by a clot, there is a potential connection within pulmonary hypertension. In the secondary hypertension, it is a high blood pressure that caused by underlying conditions such as kidney disease or hormonal imbalance. So, because of the progressive lung disease that make it difficult to breathe, there will be some changes in the airway or retained secretion. In the changes in the airway, there will be airway inflammation, which is a chronic inflammation in the airway caused by swelling or mucus production and narrowing, which restrict airflow. Second is the airway remodeling, which is over time the walls of the airway become thick, which reduce the airflow and the lungs function. So blocking airflow and reducing the effectiveness of gas exchange, which is the oxygen and carbon dioxide, is changing in the alveoli. There will be a reduced alveolar scintillation, which is there will be an airway obstruction, air trapping, and impaired exchange. So it can cause by COPD, chronic obstructive pulmonary disease, which is the underlying lung disease. This is a classic example of how a lung condition can cause or worsen high blood pressure in the systemic circulation.
So now let's get back to the pulmonary hypertension. So pulmonary arterial hypertension that occur in core pulmonale is due to a known cause. It may be because of the primary or secondary type of pulmonary hypertension. So these increases up to 45 millimeters of mercury and more. So and this increased pressure results into the increased ventricular workload as the right ventricle has to pump harder to pump blood through the lungs against high pressure to maintain the blood flow. So this leads to the vascular remodeling or the thickening of the vessel wall that causes decrease in compliance because of the stiffness. And these result to the worsening of the pulmonary hypertension. So this leads to the ventricular hypertrophy or the enlargement of the tissue and the muscle of the right ventricular wall. Through this continuous increase in pressure and workload, it overstretched the ventricular wall or what we call dilation and become weaker, reducing the efficiency that later on result to the failure of the heart. And as the effect of the failure of the heart, the blood backs up into the systemic circulation, causing venous congestion.
The signs and symptoms of the cor pulmonale is a trouble breathing, fatigue, lack of energy, chest pain, swelling in legs and belly, trachinopia, hemoptysis, jugular vein distension, and passing out during circulation. So in the physical examinations, we have blood tests, which is a series of blood testing is required to check for antibodies level. Echocardiogram, this is a diagnostic technique uh, for a cor pulmonale. It is to help the evaluation of the right and left ventricles function. It can also assist the right ventricular pressure. However, it is quite limited in assessing pulmonary function. So next is chest ray. This is a form of imaging can present right ventricular enlargement or pulmonary artery enlargement, which can help a physician suspect a presence of cor pulmonale. There will be electrocardiography, which is a ECG tracing, can provide evidence for the right ventricular hypertrophy. So next is CT scan of the chest, which is a scan of the chest can help with detect lung problem, including the presence of blood clot. Next is lung function test. This can help evaluate on how well the lungs function. Next is the right heart catheterization. This procedure includes the insertion of the small catheter into the artery toward the coronary arteries. Image are taken while the construct dies in the injection. Biopsy, a small tissue sample of a lungs, is rarely needed in assessing of the underlying lung problem.
Now let's come on to the medical management. First is we have anticoagulants. These prevents thrombotic events like pulmonary embolism, which can worsen right-sided stain and cor pulmonale manifestation. Next is we have bronchodilators. This relaxes airway muscles, facilitating clear airway and mucus clearance, thereby alleviating symptoms of respiratory conditions like COPD, which can exacerbate cor pulmonale. Next is we have corticosteroid. This reduces inflammation and respiratory conditions, improving lung function and potentially mitigating right heart stain. Next is we have cardiac glycosides. These provides modest improvement in right ventricular function, though caution is needed in hypoxic and acidotic states to prevent arrhythmias. Next is we have diuretics. So as we all know, diuretics alleviates fluid overload and right ventricular filling pressure, improving cardiac function. This requires cautions to use to avoid adverse hemodynamics effects. So next is we have oxygen therapy. So this ensures adequate oxygenation, reducing hypoxemia-related organ damage and improving overall function in patients with chronic respiratory conditions. Next is we have vasodilators. So these agents help in reducing pulmonary arterial pressure, showing moderate benefits in chronic cor pulmonale, especially in patients with specific subsets. So next is we have beta-selective antagonists. Besides managing heart rate and rhythm, they also promote bronchodilation and mucus clearance, which may indirectly benefit cor pulmonale. Next is we have phosphodiesterase type 5 inhibitors. This enhances vasodilatory effect of nitric oxide that improves pulmonary circulation and exercise capacity in patients with pulmonary hypertension. Next is we have thiopidine. This offers bronchodilation and may decrease pulmonary vascular resistance, ultimately in patients with COPD. Lastly, we have thrombolytic therapy. This rapidly resolves blood clots in acute pulmonary embolism. So this alleviates acute cor pulmonale and restoring pulmonary flow. So now let's come on to the surgical management. So first is we have phlebotomy. So this is a medical procedure that involves drawing blood from the vein using the needle. So the doctor usually removes a specific amount of blood from the body and then replace it with fluid, usually with saline solution. So this helps in reducing blood number and at the same time blood viscosity. So next is we have embolectomy. So this is a surgical procedure that remove blood clots. So this helps in improving the blood flow. Next is we have heart and lung transplant. So this is a surgical procedure that replaces a damaged organ. Now let's come on to nursing management. So we have close monitoring and assessment. So first we have oxygen saturation. The assessment of oxygen saturation is important to assess the effectiveness of oxygen therapy and to determine if the patient is adequately oxygenated. Decreased oxygen levels can exacerbate cor pulmonale symptoms. Secondly, we have intake and output. So monitoring fluid intake and output can help prevent fluid overload, which can worsen right heart failure. So third, we have electrolytes. So electrolyte imbalances, particularly potassium and sodium, can affect the cardiac function. So regular monitoring allows for timely intervention. So fourth, we have monitoring edema. So observing peripheral edema help assess the severity of fluid retention and heart failure. So increased edema may indicate worsening of cor pulmonale. So daily physical examination for signs of swelling in the lower extremities and reporting any significant changes in limb circumferences can help in assessing the severity of the disease. Promoting activity tolerance. So first we have cardiac rehabilitation. So structured cardiac rehabilitation program aims to improve cardiovascular fitness, which may enhance activity tolerance in patients with cor pulmonale. Secondly is we need to avoid vigorous activity because encouraging low impact activities prevents overexertion, which can lead to complications in patients struggling with cor pulmonale. Next, we have managing of fluid. So first, we have daily monitoring of weight. So daily weight measurements can provide early signs of fluid retention. So this can help in adjusting the diuretics and the dietary plan. So second is we have promoting low sodium diet. So a low sodium diet helps to minimize the fluid retention and manage blood pressure. And third is frequent positioning of the client. So changing positions regularly can help promote venous return and alleviate symptoms associated with fluid overload. Having a disease can really give you a lot of anxiety and stress, so we have to control the anxiety. First is we have to provide physical comfort, such ensuring a calm environment with appropriate temperature and meditative distraction to alleviate stress and anxiety, which may contribute to cardiac strain in individuals with cor pulmonale. Next is we have to provide psychological support. So this support can assist in reducing anxiety-related symptoms that can negatively impact the heart function. So we can also refer the patient to the psychologist or counselor for better coping strategies. Lastly is we have health teaching. So first we have activity and exercise recommendations. So educating patient on safe levels of physical activity can enhance both physical and psychological health, particularly in a rehabilitative context. It's part of it is creating a personalized exercise plan that include light walks and stretching exercises. Second is we have to teach Breathing techniques, because proper breathing techniques can enhance oxygen delivery and reduce the work of breathing in patients with COR pulmonale. Next is, of course, the low sodium diet. I have mentioned it earlier, reinforcing dietary guidelines to managing fluid retention and heart health is crucial for those with COR pulmonale. Fourth is how teaching the patient to use relaxation techniques. So incorporating these relaxation techniques into daily routines, into daily lives can mitigate the effect of symptoms and stress. So fifth is smoking cessation. So smoking cessation is a fundamental in improving pulmonary health and thereby reducing the core pulmonary symptoms. Lastly, the managing of equipment and medication. So, educating patients on the proper use of equipment like oxygen therapy and adherence to medication regimens is vital for managing core pulmonale effectively. So, for example, conducting workshop on using nebulizers and understanding the prescribed medication and their side effects. Finally, let's come on to prognosis. So the prognosis of cor pulmonale is variable dependent upon the underlying pathology. So the development of cor pulmonale as a result of a primary pulmonary disease usually heralds a poorer prognosis. So let's come on to highlights. The cor pulmonale is a right ventricular dysfunction from a long-standing pulmonary hypertension. Next, all lung diseases can cause pulmonary hypertension, thus cor pulmonale. Next is dyspnea upon exertion is the most common symptoms. And then lastly, primary treatment aims to treat underlying conditions.